you know, that, either you wanted to talk about common diseases, which you're going to see on a day-to-day basis, or sometimes you want to talk about those fatal diseases, which you can't afford to miss. And I think this kind of falls into that category. Plus, on the same note, there's been significant improvement in our understanding of some of these processes, which are not only relevant to us as providers, healthcare providers, but also have an impact in West Virginia population. And I'll talk a little bit about that as to how. So next slide, please. So what we're going to be talking about is pulmonary hypertension, specifically within the domain of chronic lung disease, which is the group 3 PH, which will be pretty surprising to some of you, because that's generally not the context which we talk about pulmonary hypertension. Number 2. Next. Yes, and we're going to be talking about some of the challenges in managing these patients. Again, next. And some of the updates from the European Respiratory Society on the pulmonary hypertension guidelines, which have recently been published. And then I'll talk a little bit about our multidisciplinary care, taking care of these complex patients. Next slide, please. So before we start, I wanted to kind of acquaint you about the history of pulmonary hypertension. This is looking about almost a span of century. So a lot of people think it's a new diagnosis, just came up around in the last couple of decades, but actually it was first discovered or found out by Romberg in almost 1891, where he was looking at autopsies of patients and found that some of these patients had really mangled up pulmonary vasculature, almost looked like a scar tissue, and he called that pulmonary sclerosis. Didn't know how this was connected to the overall big picture, continued to work on that, but you can see that 50 years passed by, and there was really not much understanding beyond that initial discovery until Forsman came in and did the first right heart catheterization. And we started to understand that there are two aspects of the disease. One is the structural and there's the hemodynamics, and you can't understand the disease without having both these vantage points. And that's where some traction on this disease started, where you can see in 1950s, Dressdale started to look at the hemodynamics as well as the anatomical aspect of it and seeing if they can reverse it with certain medications. And these experiments were not exactly very successful. And then it was kind of let go from there onwards. The big lesson in this whole thing was it's a very complex disease. And even until 50, 60 years, very few people were involved in pulmonary hypertension, either in the understanding or research on that. It was not even in the consciousness of physician world, and certainly not in the public's world. So what changed? So somewhere around 1965, a medication called Aminorex was introduced in Europe, specifically in Austria, Switzerland, and Germany. And what does Aminorex do? Well, it was designed as an appetite suppressant. So it became very popular with young women who wanted to get married and wanted to get fit and be able to wear the dress they want. And all of a sudden, it was a rage in that region. And suddenly they started noticing that many of these young women were landing up dying. And they didn't know why they were dying. And further evaluation of the autopsy showed that their right ventricle was failing. And there was no reason for healthy young women to suddenly have a right heart failure. And they, being told, also had the same autopsy findings which Romberg had described almost 100 years ago with sclerosis. And that's how they connected the dots that this is pulmonary hypertension, and these young women are dying of that, and they wanted to see if this new medication introduced in that area for weight loss suppressant had anything to do with that. And that's how it burst into public consciousness for the first time. And the World Health Organization organized the first meeting of getting all the experts on the table to say, we need to fix this problem and figure out what's causing deaths in these young women. And you can see from the timeline that the first meeting of WHO in 1973 to now, in just about 2 decades period of time, we have 14 FDA-approved medications for pulmonary hypertension. We know so much about pulmonary hypertension. We know the classifications of pulmonary hypertension. And based on this progress, the World PH WHO, under the auspices of WHO, meets every 4 years to see what's going on. So that, in a nutshell, is how pH came bursting into the public consciousness. Next slide, please. So most of us are familiar with the classification. There's 5 classes, 1, 2, 3, 4, and 5. And majority of our focus at any given time, even in the past when I have talked about pH, is group 1. Because of all the medications which I talked about, the 14 FDA-approved medications and the management, it is basically targeted for group 1. Why? Because all other groups were thought to be secondary pulmonary hypertension and you need to treat the base disease. For example, group 2 is congestive heart failure or the left heart failure causing right heart failure. So, hey, why not treat the left heart failure, which will improve the right heart failure? Similarly, in group 3, it is because of your lung problems. Why don't you handle the lungs and maybe the pH will improve? The group 4 is your pulmonary embolism, fix the pulmonary embolism, and hopefully the pH will improve. So those were traditionally non-touched, except for the group 3. So group 3, there have been some interest over the last 20 years without much success as to the understanding. So today's talk is going to be focused purely on group 3. Next slide, please. So let's start with a little case over here so everybody gets an understanding as why we are moving into group 3. This is a 65-year-old former smoker, a history of obstructive sleep apnea, idiopathic pulmonary fibrosis, presents with worsening dyspnea, fatigue, mid-leg swelling, and so several months. Now, this is not an unusual case for any one of us to see on a regular basis. He's a smoker. He's got some potential COPD. He lives in West Virginia, maybe has some exposure, and now he's got IPF. Very, very prototypical case. Next slide, please. So IPF was diagnosed 3 years ago, has been stable for that period of time, but uses oxygen at the rate of 2 liters at home. And you examine him, he's not in distress, he's 97% 2 liters, but there's a prominent S2 and there's slight JVD, mild bibasilar crackles, and some trace pedal edema is noted. And if you can look at the PFTs, you'll see that the ratio is kind of well preserved. So even if you had a COPD, it doesn't look like it's severe. He does have total lung capacity, which is moderately reduced to 69, but not hugely. But diffusion capacity, DLCO, seems to be out of proportion dropped compared to his obstructive or restrictive disease. Next slide, please. So this is his CAT scan, and anybody looking at images on the lungs will note it right away that yes, there appears to be some interstitial marking, maybe some subpleural honeycombing, and this is lower lobe, so very consistent and high probability of a IPF, and based on the PFT, you could say probably like a mild to moderate IPF. Next slide, please. So traditionally, there was really nothing much but to offer antifibrotics, oxygen, maybe if the patient qualified for a lung transplant to set him up on that track. But group 3 generally comprises of these kind of patients. You have interstitial lung disease, you have obstructive lung disease like COPD. You have probably patients with bronchiectasis, patient with hypoventilation syndrome, or mostly obesity hypoventilation syndrome, not necessarily OSA, and some developmental lung disorders. So that's the group we are talking about, very common in West Virginia. Next slide, please. And you can see some imaging over here where you can see huge bullous disease, very ominous of severe obstructive lung disease or COPD. Next slide, please. And this one, of course, in the other side of the spectrum, severe restrictive pattern on the lung disease with increased interstitial markings and fibrotic changes, bronchiectasis, and subpleural honeycombing. Next slide, please. And this is your hypoventilation syndrome, obesity hypoventilation syndrome. I may remind this crowd that we still remain the heaviest state in the country, so obesity hypoventilation syndrome is a common diagnosis over here. Next slide, please. And of course, another example of very, very severe obstructive and COPD example. Next slide, please. Okay. So we're looking at interstitial lung disease, and surprisingly, 30 to 50% with interstitial lung disease will have pulmonary hypertension. And majority of these patients have mild to moderate pH. So one of the issues which people have a hard time grasping is that, oh, my patient only has mild disease. When it becomes severe, then I'll worry about pulmonary hypertension. It's actually, if you look at the data, majority of the pulmonary hypertension occurs in the mild stages. So I'm going to show you that data in the next slide. Next slide, please. Similarly, in COPD, COPD is a little bit different than interstitial lung disease because it really correlates with the severity of the COPD, I mean the pH. So the worse the COPD, the worse the pH, unlike interstitial lung disease, where there's not much correlation between the two. Next slide, please. So as I said, that you would imagine or believe that, intuitively, it makes sense that the worse the disease, the more the parenchymal abnormalities, the more the pulmonary hypertension. But this is a study done by Steve Nathan and his group at Fairfax, where they looked at the FVC and the PFTs and the amount of pulmonary hypertension. You can see that people with almost near normal PFT with interstitial lung disease with FVC of more than 70 are the ones which have the highest degree of pulmonary hypertension. So early recognition, early diagnosis is the key of not only recognizing, but be able to do something about this disease. Next slide, please. So pathophysiology, next slide, please. Common pathways. Basically, there's an endothelial injury because of some free radicals which get unleashed because of this damage in the lungs. And there's a loss of alveolar vascular complexes, especially when you talk about severe emphysema. And from the vessel injury is very similar to group 1, including endothelial dysfunction and vascular remodeling. There's been an increased interest in our cellular biologists of having found out a molecule called the hypoxia-inducible factor, or HIF. Next slide, please. And what basically is the HIF acts like a switch, because a lot of us may have questions. Well, here is a whole bunch of COPD patients. I have a huge population of interstitial lung disease. How come not everyone gets pulmonary hypertension? And that's explained by this molecular switch theory, in which it depends on whether the patient is genetically designed to kick off a hypoxic-inducing factor, or the HIF. And if he does upregulate the HIF, then it leads to much more severe vascular damage rather than parenchymal damage. On the other hand, if this molecule is not upgraded, then it leads to more of a parenchymal disorder and dysfunction rather than endothelial. So depending at some point of the disease process, this molecule decides which pathway is going to be taken, whether there's going to be more parenchymal injury or more vascular injury. People who get more vascular injury then progress on to have pulmonary hypertension. Next slide, please. So the other question, the practical question which gets asked is, but how is it important? Why does it affect me or my patient? Well, this is the reason, is that if you look at any patient with your interstitial lung disease, then if you have PH versus no PH, everything else being equal, they have much higher mortality. So they have much higher mortality in the first year mortality, which is almost 30%, as opposed to if you didn't have PH of only 5.5. Even if you take it over the 5 years period of time. Next slide, please. You can see the event-free, transplant-free survival is much worse in patients who have pulmonary hypertension than in don't. So this brings to the question, yes, PH is hurting my patient. They're probably going to die sooner. What can I do about it? Next slide, please. This is the same situation that the previous slide was for interstitial lung disease. This is the same for COPD, showing increased mortality with PH as compared to non-PH. Next slide, please. So how do you suspect it? All of your patients with lung disorder would have the same issues: shortness of breath, they may have cough, and they have fatigue. So the diagnosis often is delayed because we get to our default understanding that, hey, this is just the process of a evolving, worsening disease of underlying interstitial lung disease, and there's not much we can do. Few tips are that they are out of proportion short of breath to what you're seeing on the paper. They may have a little bit more fatigue. They have more chances of being dizzy, and they may show signs of right ventricular failure. How do you pick up those signs? Well, these people may talk to you about dizziness. Hey, doc, when I get up from a sitting position, I feel dizzy. If I go up the stairs, I feel that I'm going to fall. You examine them and you see there's a little JVD. Well, usually most patients with COPD and ILD shouldn't have a JVD. The diagnostic approach, next slide, please, is basically that you have to have a high suspicion for pulmonary hypertension and take it with assumption, if you have an interstitial lung disease, if you have a patient with COPD, that I should be looking for pulmonary hypertension in these patients. So a proactive approach is much more beneficial than waiting for the symptoms to advance to the point that the RV collapses. Next slide, please. Next slide. Okay. You keep pushing that button because these are some of the general testing which we do, the lab work and EKGs, PFTs we talk about. Of course, one of the best screening tools we have is echocardiography. So anytime you have interstitial lung disease, COPD patient who is out of proportion, short of breath, and echocardiography is important. Chest imaging is helpful in terms of getting a CT chest rather than just an X-ray, because it can give us a good idea of what I'm going to talk about. Some of the biomarkers or imaging biomarkers can be helpful. Advanced diagnostic approach may include VQ scan to rule out chronic thromboembolic disease, cardiopulmonary exercise testing, and eventually the gold standard for diagnosing PH-ILD is a right heart catheterization. Next slide, please. So pulmonary function test, a couple of things about it. Next slide, please. Is that it's very helpful. There's, immense data, which is not on the slide, is that DLCO, which is out of proportion to the rest of the PFT, is a suggestion of early pulmonary hypertension, even if the echo doesn't show that. So it's a good marker to, or a good biomarker to find out about early pulmonary hypertension. But on top of that, if you look carefully at the ratio of the FVC to DLCO, it is actually a prognostic marker once the diagnosis of PH-ILD has been made. And any rise in FVC to DLCO ratio for more than 20% is suggestive of a poor survival in these patients, which means you need to move faster, need to diagnose them faster, and have some therapeutic options, whether it's transplant or medication, readily available for them. Next slide, please. All right, so I was talking about why CT imaging is important in these is that we have found out in the last few years that some of the findings on the CAT scan can be very helpful in the diagnosis of pulmonary hypertension. For example, if you look at the imaging, the first image, which shows the pulmonary artery, if the diameter of that pulmonary artery compared to the aorta, which is right next to it, is more than 1, then not only does it suggest that the patient may have underlying pulmonary hypertension, it also is a very good prognosticator, because these patients have a much higher mortality compared to people whose pulmonary artery is smaller than the aorta. So very important thing, because everybody has a CT scan, so you don't even have to sometimes go to an echo. You can say, hey, he had a CT scan 3 months ago, let me look at that. The second shot I'm showing you is the cardiac silhouette. And you can see it's a contrast CT, so you can very well demarcate the right side from the left side. And you'll see the RV base is much bigger compared to the LV base. And the ratio of RV to LV of more than 0.9 is also suggestive of pulmonary hypertension in these patients, and of course, also a poor prognostic marker. Next slide, please. So very helpful in terms of workup for these patients. Echocardiography, as I said, is an important tool, is a screening tool. It does not a gold standard diagnosis, but if you look at the echocardiogram and you see significant tricuspid regurgitation, which is defined as more than 3 meters per second, then that is highly suggestive of pulmonary hypertension. Next slide, please. And these are all some of the equations we use to calculate the right ventricular systolic pressures. And the only reason I put this on here is that sometimes in echo report, they'll mention TRJAT, and others they'll say RVSP, and in others they may say pulmonary artery pressures, and they're basically the same thing. Next slide, please. Next slide. Okay. So the most important part, which I wanted to make sure that I get the message across, is the road to hell is paved with normal echoes. Why do I say that? Well, the same group from Steve Nathan's group in Washington, D.C., showed that 1/3 of the patients who undergo echo may have normal images, may have normal RVSP, a normal TRJAT, and still have pulmonary hypertension. And that's a big, big chunk of people. If 1/3 of those people, you're missing the diagnosis. So you have to be very careful, and that's why it's a good screening test, but it is definitely not the diagnostic test. And if you have other biomarkers, which are strongly suggesting you that the patient has pulmonary hypertension, for example, pulmonary artery to aortic ratio more than 0.9. For example, your RV base being higher than your LV base. For example, if your DLCO is significantly lower than your FVC and the ratio is much higher, all of that are suggesting that this echo may not be representing the true state of hemodynamics in these patients. Next slide, please. So the gold standard, of course, is the right heart cath, in which we introduced a catheter to the pulmonary arteries, and we actually measure the pulmonary vessels. And this also allows us to differentiate the pulmonary hypertension from group 2 to group 1. Group 3, which I'm talking about, if it is a true pulmonary hypertension, which is the PH-ILD, it'll have a group 1 physiology. So remember that group, if we are talking group 3, but the hemodynamics would be very similar to group 1. Next slide, please. And this is important because for 2 reasons: what are the numbers we are looking for? And number 2, how has the definition evolved? And what are the latest guidelines? So if you look at the top part of it, the pulmonary hypertension is no longer defined as the mean PA pressure of more than 25. It has been lowered down to 20 millimeter mercury. And that's because of data showing that mortality starts increasing from 20 millimeter Hg. And the people who wrote the guidelines felt that a lot of people were being delayed in diagnosis and opportunity being missed by having a cutoff which was higher. You'll also notice that your PVR, which used to be 3 Wood units, have been reduced to 2 Wood units. So these are some significant changes which have lowered the bar for diagnosis of pulmonary hypertension in these groups. Next slide, please. And here's the stratification that in this group 3 PVR has become a good dichotomization tool in terms of severity and prognosis. So anybody who has a PVR of 5 is now constitutes a severe disease, while less than 5 constitutes a non-severe disease. And these can be instrumental and helpful when evaluating patient for transplant. For example, severe PH may not be a candidate anymore for pulmonary for lung transplant until we help reduce some of those pressures. Next slide, please. So phenotyping of PH and chronic lung disease. This is an interesting slide for clinicians to know, because you're going to see that X-ray and CAT scan on the top and bottom of 2 patients. And you're going to look up at the first one and say, I do see some interstitial lung disease, maybe some subpleural disease, but it is not looking too much, is not too impressive for me. While at the bottom one, which is the same age person with a similar amount of dyspnea and cough, you can say this is significant amount of IPF. You can see that the right side is pretty much very, very fibrotic, and there's huge amount of honeycombing, much more than that. And then if you were to be thinking in terms of logic, you would say the bottom person has much severe pulmonary hypertension as compared to the top. So let's go and see. Next slide, please. Next one. So this is the echocardiography picture of both of these patients. On the top one, you can see that the right ventricle is under much more tremendous pressure and is almost compressing the LV, suggesting very severe pulmonary hypertension, and that is corroborated by the TRV or TRjet of 4.2 meter per second, which is significantly higher, as compared to the bottom one, where you can see the left ventricle is much bigger as compared to the RV, which is what normally happens, and the tricuspid velocity is 3 meters per second, which is borderline high only. Next slide, please. And you can see that the PFTs are not much different in either one of them. So if you were to go by the PFTs and the CAT scan, you would refer the patient who is either borderline or mild pulmonary hypertension, but completely miss the first person who's got severe pulmonary hypertension and possibly is going to decompensate and die much more sooner. Next slide, please. And this is just basically the right heart cath data on these patients. You can see how severe the pulmonary hypertension with mean PA pressure of 48 as compared to mean PA pressure of 26 in the second one. Next slide, please. Next slide. All right. So coming to treatment approach, I think you're well familiar with the 3 pathways of pulmonary hypertension. I'm going to focus mostly on the group 3 and what's been going on in our research from that perspective. Next slide, please. So early treatment and early referral to PH with individualized care in this PH-ILD is very important. And the next few slides will be devoted as to why it is important for them to have a multidisciplinary team taking care of not only the diagnosis, but the management. Next slide, please. Next one. Okay. So here's the snapshot. I haven't included every study, but you can see that since last 20 years, there have been a lot of work trying to figure out if the same medication which worked for group 1 worked for group 3. And unfortunately, majority of the trials failed, and we call sometimes this as the graveyard of the group 3 trials, and none of them ever has shown any benefit in group 3 PH or ILD-PH, except for the last 2 ones in which this group with Steve Nathan had used an inhaled nitric oxide and shown some improvement in 8 weeks period of time. And then the second study, which I'm going to talk to you about. Next slide, please. So effect of prostacyclin. So prostacyclin, among the hierarchy of FDA-approved anti-pulmonary hypertension medication, is one of the most powerful medications of pulmonary vasodilators known to us. And it has always been of interest to pulmonologists and researchers because it not only reduces those pressures very, very dramatically and quickly, but it also has an impact on right ventricular remodeling and function. So that we've thought that this could play a good role in our understanding of the group 3 pulmonary hypertension. Next slide, please. And this is a molecular animal test just to give you a little idea about how the prostacyclins work. On the top slide, this is a mice model of the lung, and as a control, they're been inhaling saline in A, and then after 21 days, you see, yes, saline may not be good, but they have pretty much maintained their lung architecture. It doesn't look too different than the previous one. But look at the bottom one. This is a patient, this is a mouse model which has been inhaling bleomycin, a very, very toxic substance for the lung. And you can see pretty much the complete destruction of the alveolar interface over here. However, when they were treated with prostacyclin, specifically treprostinil, which is a synthetic analog of prostacyclin, you can see regeneration and remodeling and some semblance that your lung is starting to heal itself, and you can see some alveolar components of it. So this was very interesting study, which propelled us to see whether this could do a similar thing in the human population. Next slide, please. So this was the first study, randomized controlled trial published in New England Journal by Steve Nathan and his group. And basically they looked at inhaled treprostinil in patients with interstitial lung disease and pulmonary hypertension. Next slide, please. And this was a 16-week study, and the patients were dichotomized, randomized to placebo versus receiving inhaled treprostinil through this contraption or the nebulizer. And you can see at the end of the 16-week, they saw significant improvement in the walk distance, which was about 20 meters longer than placebo, which in some, areas doesn't feel too much. But if you look at interstitial lung disease and PH patients who can barely move from their couch, and need help even to do their daily ADLs, 20 meters is a relatively significant distance. Next slide, please. They also found, interestingly, as a secondary outcome, that BNP, which is a marker of RV dilatation, had significantly reduced in the treatment group, but did not improve, but actually worsened in the placebo group. So again, suggesting that hemodynamically, RV must have been relaxing for the BNP to get better. Next slide, please. So based on these are the hemodynamics of it. You can see the etiology of PH-ILD was quite varied. It varied from idiopathic interstitial pneumonias to CPFE to connective tissue disorder and others. And based on this data, next slide, please. In 2017, it was FDA approved for use in this specific population, group 3. So this by far remains the only medication FDA approved for PH-ILD and is available. So how does it kind of correlate, as I was initially alluding to you, and for West Virginia? What's different about us? How do we take this national information about this fatal disease and then try to make sense out of it from our Appalachian perspective? Next slide, please. So one of the things which we all are aware of, that we are one of the highest smoking states in the country, which automatically puts us as the number one COPD states in the country. And not previous slide, please. Yeah, I think. And by default, we have the highest death rate from COPD and the highest readmission or admission to the hospital because of COPD. So we also have significant coal miners disease, again, intertwined with that. So that can also lead to interstitial lung disease and pneumoconiosis. Next slide, please. While I was researching for data on this particular subject, I came across a very interesting article, which was published in 1971. It was published by N. Leroy Lapp. Some of you may be familiar. I carry the chair position by his name. And he actually, even at that time, and you may say, well, whatever you were talking in the last 30 minutes is all new, brand new. These people already knew about it, and they'd looked at pulmonary hemodynamics and symptomatic coal miners and found pulmonary hypertension was present in these patients with massive pulmonary fibrosis, and it led to increased mortality. So these guys were pioneers and knew way more even at that time than what we are trying to figure out now. Next slide, please. So coming back to West Virginia, is that this is a very important study. It's an important study because it's a failed study. And sometimes failed study teach you more than successful study. Interestingly, it was carried on by the same group which did the NEGM study on the inhaled treprostinil by Steve Nathan and his group. And here they used a molecule called rioxyguat, which is a pill and works on the nitric oxide pathway to see if a pill could reduce pulmonary pressures in these patients with interstitial lung disease. And lo and behold, the study had to be prematurely terminated because more people who were on the PH medicine started dying compared to the placebo. And the authors and the researchers were very intrigued that from pathophysiological point of view, it makes sense, but why are the people dying? So what they did was they just didn't shut the study and put it in the cans to rot. They looked at data very, very carefully. And they went in and looked at each patient as to what was different about it. Next slide, please. And guess what they found? They found the people who died and shifted the balance towards a negative study were the patients who had CPFE, or the combined pulmonary fibrosis and emphysema, which means they had both interstitial lung disease and COPD component, not just interstitial lung disease. So that the disease started to be treated as interstitial lung disease, but these patients had a combination which they failed to recognize. So why is this important for us in West Virginia? Next slide, please. Because we did our own study in West Virginia even before all of these studies a few years ago, and we found that we have one of the highest prevalences of CPFE. 45% of the patients considered interstitial lung disease in West Virginia were found to have CPFE instead of ILD. So that gives us a breather. And again, coming back to my previous lectures and talks, is that you can't always take national data and say what's good for New York is good for us, and what is good for Atlanta must be good for us. And that's where local factors play a role. And we felt that this is a very important piece of information because if CPFE is so high and that pulmonary vasculature medications did not help in that, in fact, made it worse, then how is it going to play out in West Virginia? So what we started doing is we started doing a multidisciplinary meetings there. Not only we had interstitial lung disease specialists, we had pulmonary hypertension specialists, and we had radiology specialists, and we started grading these patients whether one of the A or B they had CPFE or not. And if they had CPFE, at what percentage of CPFE was there in order for them to either benefit or have a bad impact in the outcome. Next slide, please. So this is the model which we have framed over the last good 8 months. And we have piggybacked on the interstitial lung program, which has been operational for over 2 to 3 years at our place. And I'm going to walk you through this, what we did. So we looked at all the interstitial lung patients in our program, and we found 191 patients which at least were labeled in the EPIC as interstitial lung disease. We carefully looked at each one of these patients. We found that 127 of them had true ILD, and 64 were eliminated because we didn't think there was sufficient data to call them ILD. We took that 127 patients, and then, of course, by the time a lot of people outside our institution started knowing that we are running this PH multidisciplinary program, so they started referring, so we included some of those patients. And then we applied the screening protocol to all of these patients, which is the block on your right side. You can see whether they have a BNP of more than 200, whether they had an FVC to DLC ratio of more than 1.6, where their echo shows more than 40 millimeter mercury RVSP, or the TR jet of 300 centimeter per second, or their PA to arterial ratio, as we looked at the CT scan, was more than 1. And if they were positive on any one of these criteria, they were labeled preliminary as PH-ILD. And we found that 66 patients were identified as a preliminary PH-ILD, out of which 18 have already underwent right heart catheterization. Actually, we have done 3 or 4 more in the last 1 week, so this number is growing. Out of the rest of the 48, 5 died, because obviously this is a very sick population we are talking about. And in the other one, we are still debating whether these people qualify for preliminary diagnosis of PH-ILD, and 13 of them we ruled out as low pretest probability. So a very intense group of people looking at each one of these patients very carefully and determining whether these patients should proceed for further evaluation and treatment. Next slide, please. So this is kind of gives you an idea, very similar to the New England Journal, that we have a very, very rich variety of interstitial lung disease here in West Virginia, all the way from IPF to connective tissue diseases, sarcoid, occupational exposure, hypersensitive pneumonitis, you talk it, we have. So very rich population was included, and many of these patients had pulmonary hypertension. Next slide, please. So now, when we did the hemodynamics, what did we find? So lo and behold, these patients, remember, none of these patients was actually referred in the first place. Nobody was recognized. This is a screening process. In the screening process, in the 18 hemodynamic studies of right heart caths, we found that 80% of these patients had pulmonary hypertension, out of which 55% had precapillary, which is basically PH-ILD in the true sense with group 1 physiology. And 22% had no pulmonary hypertension, and about 22% had postcapillary. Postcapillary is group 2, which basically suggests that there is a problem with the left heart, and that's what needs to be focused on and not the right heart. Next slide, please. And of this precapillary 10 patients, you can see that these are the hemodynamic data, and you can see that ranges from very high PA pressures to borderline PA pressures, and then many of them, based on our further evaluation of the CAT scan and determining that they don't have significant CPFE, were placed on inhaled treprostinil. Some of the more severe versions of them were placed on both treprostinil and a PD-5 inhibitor, and we are now following their outcome over the next few months period of time. Next slide, please. So in essence, there's one and the only program in West Virginia that we know of PH-ILD model. We welcome patients from any place in West Virginia, surrounding areas, if they have any suggestion of interstitial lung disease or COPD, specifically if they have clinical suspicions of PH, as we alluded and discussed about. Once they are referred to the PH, Then we do a guideline-based workup with a combination of PH, ILD experts, CT scan, and cardiologists and radiologists. You can see the multidisciplinary team, which meets once a month. And then we dichotomize these patients, whether they have group 3 physiology or phenotype or group 1 phenotype. And of course, group 3 phenotype is further defined by CPFE presence and degree of CPFE presence, whether they would qualify for inhaled treprostinil or not. And group 1 phenotype is doors are much more wider open because we have 14 FDA approved medications now for group 1 phenotype PH. Next slide, please. So this is the clinical program, and we are undergoing IRB based trial. And what does this trial do is that we are looking specifically at West Virginia Appalachian population. How are they different from what the national data which we have been exposed to so far? Do they respond in the same way to the medication as we've been told the national people do? Because we think there are significant baseline phenotypic and other structural abnormalities and differences between the West Virginian population and others, we need to be very careful in our evaluation, documentation, and outcome of these patients. And that's the IRB, is to figure that thing out as to what's best locally for our patients with this very, very fatal disease. And with that, I have come to the end of my discussion, but I am sure a lot of people have a lot of questions, and I'll be more than happy to answer them. Thank you.
Thank you so much, Dr. Sharma. That was a wonderful presentation, just very thorough. We really appreciate that. Does anybody have any comments or questions?
Oops. I have a quick question here. Sorry, I got weird dynamics. There we go. That's better. The quick question is, you mentioned a lot of times IPF, which I presume is idiopathic pulmonary fibrosis, is the underlying disease. What about pulmonary fibrosis with known causes like black lung, which is the population I work with primarily? And how would the treatment or the assessment and/or treatment be different in that population?
Nicole, that's an excellent question. As I said, that we know very little about it, but I had alluded to a slide which I found out, which Dr. Lapp, Leroy Lapp, had published in the Blue Journal in 1971, and he showed significant pulmonary hypertension, even in interstitial lung disease associated with the black lung, and especially in massive pulmonary fibrosis. They had very high prevalence of that. Now, remember that in 1971, there was no treatment available. So it was mostly a documentation that these people are somehow getting pulmonary hypertension, they are dying. And that, to me, is mind-boggling for our researchers in West Virginia, way ahead of time, to have documented it in 1971. If I hadn't researched all the way to the last 100 years, I would not even have found this documentation. There is no mention of it. But now I think they come to what is our responsibility is to see how these patients respond to these medications. Now we have 14 FDA medications approved, but one specifically for interstitial lung disease related IPH. And that's the area which we are focusing on this IRB study, which we are conducting. And yes, coal miners disease are prone to it. They should be evaluated, they should be monitored, and we should look for evidence of improvement with the newly FDA approved medication in them.
Okay, just as background information, Lee Lapp's paper is the reason that core pulmonary is one of the ways to qualify for black lung benefits, which is the 30-year-old vocabulary for all the things you've been talking about today.
That's right. That's right. Right heart failure. But I think that, what we have kind of learned in the 30 years is by the time you have core pulmonary and RV has already pooped out, there's not much we can do. Of course, leave the compensation part apart, but I think to save their lives, prolong their life, or make them breathe easy, we need to pick them up much earlier in the milder stage.
Thank you so much for the question. Thank you. Does anybody else have any comments or questions?
Yeah, Elizabeth, I do. This is Dan. So,
Hi, Dan.
Dr. Sharma, thank you. That was an amazing lesson in pulmonary physiology and pathophysiology for us. That was really cool. And I feel like for this group, like for the respiratory therapists, Lisa and Johnny and Terry and Aaron, we need like one more slide, which is, okay, you guys out there on the front lines, you might not understand all this sort of sophisticated right heart cath, terminology and everything, but here's the bottom line. Here's the takeaway. And I think, and even for primary care docs like me who are struggling on some of your slides to appreciate what all the, which is the right heart, which is the right atrium, and where's the pulmonary artery and the aorta there. It seems like it's going to be something like the high prevalence of combined interstitial and obstructive disease. And of your 5 screening tests that you listed on that one slide, we can do the BNP, we're doing the spirometry, we're doing the DLCO, and I think, and the respiratory therapists are going to spot it more than the primary care docs because they're more into the spirometry. And so it seems like recognizing that combined severe restrictive and obstructive pattern, they've already learned that they've got to do CT scans, and a lot more they're doing CT scans than relying on chest x-rays because they're dealing with severe black lung, and they know that the CTs are more sensitive for black lung. So our RTs are doing the spirometry, they can do the BNP, they can do the CT scans, they can spot the combined. And at that point, I think we call you up or send them to you.
I think that's a fantastic summary of everything, Dan. I think that you very rightly mentioned that many of these tests are being done, but if we could just connect the dots and say, hey, these 2-3 things are aligning to what I heard, and I know already this patient has Coles-Miner's disease. His X-ray and CAT scan show either obstructive or restrictive disease, and now I see his BNP is elevated for no reason. He doesn't have any underlying heart disease. Well, his DLCO seems to be in the pits. Why? It doesn't seem to have that bad an X-ray or CAT scan. Or if you got a CAT scan and you suddenly see his pulmonary artery is wide and is bigger than the aorta, those are absolutely low-hanging fruit, very smartly picked up by a lot of. So in my slide, Dan, the last one I showed that you saw that we were doing the study on our own, but people got wind and started sending. 8 of those patients in the study came from outside because they were just immediately said, I can do this one, I can do that, and this is not matching. So I think you very nicely summed it up that this is not rocket science, at least at the base, that you can save a patient all by saying, okay, I got these 2 things, and let me just make sure that he gets to the right place where he can be evaluated for that. So yeah, it doesn't need to be guesswork. It doesn't need to be, I have to send every patient. I think these markers or biomarkers, which we talked about, can be very helpful in that initial determination.
Thank you.
Thank you.
Thank you. And thank you so much, Dr. Doyle, as always. All right. I just have a final announcement, and the next one will be on March 20th with Dr. Sela discussing chronic cough. So please be staying tuned to your email for that update and reminder. And I just really happy to see you all. Have a great week. Thank you.
Thank you.